This is Frequency, a production of the American Academy of Otolaryngology, Head and Neck Surgery.
Hello, I'm Dwayne Taylor, and I'm the president of the American Academy of Otolaryngology, Head and Neck Surgery. I'm the medical director of Le Visage, ENT, and Facial Plastic Surgery in Bethesda, Maryland, in private practice, and also clinical instructor at GW, George Washington University. And this is episode 18 of the AAO-HNS COVID-19 podcast series. And this episode will cover the developing effects of the pandemic in Africa. And I'm so pleased to be joined by an illustrious panel today and share their insights into the regions of the continent. First, I'm joined by Dr. Gail Woodson, who's a past president of the Academy and a professor emeritus and former chair of otolaryngology at Southern Illinois University, and a visiting professor at Kilimanjaro Christian Medical Center in Tanzania. Also, we're pleased to be joined by Dr. Johan Fagan, the Leon Goldman Professor and Chair of the Division of Otorhinolaryngology at the University of Cape Town in South Africa. So I'm also joined by Dr. Titus Ibekwe, Professor and Head of the Department of Otorhinolaryngology at the University of Abuja and University of Abuja Teaching Hospital in Nigeria. And he's also our former Vice Chair to the International Advisory Board. And finally, I'm very pleased to have Dr. Mohamed Goma, Professor of Otorhinolaryngology at Minia University in Egypt. And I want to thank you all for joining me today to discuss this very important topic. What I'd like to do is to start out with you giving a perspective of what the COVID-19 pandemic is like in your area, in your region, and what's been going on from your perspective in terms of what's being done right now and where you are. And I want to just also note that Dr. Woodson, although she's from the United States, she spent a lot of time in the continent of Africa, and I'd like her to share some of those perspectives and as far as what she feels things are going like in the areas that she's most familiar with. And I know she's had a lot of discussions with physicians over there as well. So why don't we start with Dr. Fagan?
Right, thank you very much for having us on this panel. The COVID epidemic or pandemic has really hit Africa after it hit Europe and North America. And we really in Cape Town, we're right in the midst of a sharp upward trend in terms of the number of infections. We were fortunate that our South African government was very proactive, and they imposed a very comprehensive sort of national lockdown very early on in the pandemic, and that has most certainly flattened the curve quite significantly and given us some time to prepare for the pandemic. But now, as is to be expected, the number of cases is rapidly escalating, and we're expecting to peak probably around about September this year. So far, we've had more than 1,300 deaths nationally, and but unlike North America and Europe, one of our biggest challenges is that because we have so many poor people living in our country, there are many people being pushed into abject poverty, and this has raised big debates about measuring the benefits of a lockdown, as we've had and we still have in part, as opposed to lifting that lockdown and allowing the number of cases to increase. And unlike North America, we simply do not have the financial reserves that you have for a strong economic stimulus and to support all those who have lost their jobs.
Thank you, Dr. Ibekwe. One of the things that we'd like to start with talking about, as we mentioned before, was your experience with the COVID-19 virus in Nigeria and how it's impacted in a general way your country and how you have been able to respond in terms of the physicians in the area.
Yeah, thank you very much, John, Mr. President. I am delighted to be part of this discourse. I think it's a very big honor to talk about Nigeria and her experience regarding the COVID-19 disease. By February 27th of this year was when we had our first case in Nigeria, which was an imported case from Italy. An Italian businessman flew into Lagos, Nigeria, and was identified to have this disease. Initially, it was received with a lot of mixed feelings across the country, some disbelief and with some, feeling of disdain all came into play. But of course, over time, it became real because we started seeing lots of cases springing up. And as we are speaking, as I said today, we had a total of 14,554 cases in Nigeria. And the cases have spread across the 37 states in the country, 36, and indeed the Federal Capital Territory, making 37. And we have had 387 deaths, and 4,494 have been discharged as we are speaking. But when this is compared to about 216,000 that have been recorded across Africa, you realize that Nigeria has contributed just 6.7% of African cases of COVID-19. And when this is further extrapolated, Nigerian population, which is about 200 million against 1.2 billion African population, Nigeria constitutes 16.7% of African population. But in terms of the disease burden, we are contributing 6.7%. And an interesting thing here is that most of the cases that we have recorded can be categorized as mild cases rather than very severe ones. Visually, all the deaths recorded are those who have some underlying illnesses, and chronic diseases. These are the category who have fallen victim to this disease. And we have been in the forefront because I still double as the national chairman of the continuing medical education for the Nigerian Medical Association and indeed Nigerian doctors. So almost every day we're in the public domain telling the populace about this disease and trying to convince them that it is real, because initially a lot of people were there with disbelief that as far as they're concerned, there's nothing like COVID-19.
Thank you. Dr. Goma?
Thank you. I want to thank Mr. President for having me on this panel discussion about COVID-19 in Africa. My insight in this pandemic is here in Egypt, we deal with this pandemic so wisely. When the first case discovered and reported in Egypt, this was at the second half of February. And after that, the Egyptian administration started to take measures, and these measures helped the healthcare workers to take a deep breath and to work wisely and to work perfectly after that. And we reached 1,000 reported cases after 52 days. So this time gave us an opportunity for the healthcare workers to deal with the situation and also to adapt PPEs, personal protective measures, to have a lot of them. And some factories, the textile factories, transmit change their production from the textile into the PPEs. And after that time, we have a lot of PPEs, and I think we are working great in this. And also this PPEs, we also gifted it to to other countries in the Europe, China, United States, and in Africa. And so far, we are in the rise in the numbers, but still the healthcare worker can adapt to increasing number, and it is not crashed like some countries.
Dr. Woodson?
I'm very happy to be part of this panel. I think it's very concerning about the effects that a pandemic can have on the countries in Africa, particularly areas that have poverty and limited healthcare resources. And at the beginning of the pandemic, I was really quite worried about my friends and colleagues in Tanzania. I spend a fair amount of time in Tanzania each year, particularly at a hospital in Moshi, Tanzania, Kilimanjaro Christian Medical Center. They only have 4 ventilators, and they serve a population of 15 million. So I was really quite concerned. As it's turned out, they've been really relatively spared. There's not that much outbreak. My colleague in Arusha, a very good friend who's a family practitioner, saw the index case in Rwanda. At the very beginning, it was a woman who'd been coming back from Belgium, and I think 4 of her contacts tested positive. They were able to trace the contacts. I think there's limited resources for testing, but there was enough in that city to do that. And no one became very ill. And when I last spoke or communicated with the hospital in Moshi, they had not had a single case. Things are back to normal. They did have a real strong program of trying to shut things down. Schools were closed. People were informed about washing their hands. People in the hospital wore masks. But you know, it's sort of like the plague has not hit there yet. I shouldn't use the word plague, but it feels like it sometimes. And there's been some question about what's going on. It may be that they live in less urbanized areas. They're more, a lot more outdoors, in the sunlight, warm weather, and less exposure to disease being imported, because it seems like the disease does come from European and Western countries, and in remote areas they just haven't been exposed that much. But there still is this real fear that if it does get into the population, it could be horrific. You look back to the Spanish flu, the first wave didn't really affect Africa that much. Came in, I think, mainly from the West Coast, and then the second wave was on some ships coming in through Zanzibar, and it really spread horribly within the continent. And I think you could probably compare the contagion potential of coronavirus pretty well to the flu. So there is still this potential. But at present time, Tanzania has been very spared. They're opening up again. The president has said, you know, we're free. I think there may be a few cases down in Dar. There's always a question about how much of this may be due to not so much testing. That question comes up in our country too, and you know, the bottom line in the United States is, well, how many people are showing up in the hospital and test positive? And it may be, I don't know, in areas of Tanzania that patients don't have access to get to the hospital. There may conceivably could be people dying from something and not be diagnosed, but certainly there's not a visible impact there. I mean, look at neighboring countries. Rwanda has only reported 2 deaths, Uganda, no deaths. Congo, I can imagine there's a massive problem with testing in a country with the resources they have, but the known cases are in the capital, and I think there's about 100 deaths so far. So it's an interesting situation going on, and we kind of just have to see what happens.
Thank you, Dr. Woodson. A couple really, I think, critical questions were raised. You know, the idea of are there enough people that are being tested to really have a handle on, you know, how many people not only have it in different areas, but also if there are areas that aren't necessarily in the main cities, are people dying of it without us really knowing? And I do hear the idea that I think you all got ahead of the contact tracing piece. Probably, I'm guessing because of what happened several years ago with Ebola. There was, I think, a heightened awareness and sensitivity, and also experience with that we hadn't had in any recent times in the United States. But could you talk a little bit about that in terms of testing, as well as specifically otorhinolaryngological procedures and some of the things that you've been doing as it pertains to our specialty? Any specific things that might be of worthwhile, or that we would want to know about, and that you are sharing with other areas? Dr. Fagan?
In terms of testing, our government was once again very proactive early on. They had a very aggressive testing program where they trained lots of field workers who went out into the communities to establish what the pattern of spread is around the country. The aim being, firstly, to try and determine how many cases there are out there, but also to try and establish where the hotspots are in the country, so one can possibly place those areas into lockdown. And the third reason being to track and trace. But our testing program has gone off the rails slightly, and the reason being that we've had a shortage of testing kits and reagents. And so in some parts of the country now, you have to wait up to 2 weeks to get your results. So at that point, to track and trace people really becomes meaningless. You really want to be able to get your results back within 24 to 48 hours, so you can then contact those people who are infected, and they can self-isolate. But of course, self-isolation is also a challenge for many of our communities, because if you live in a poor area, right cheek by jowl, it simply isn't possible to self-isolate from people around you, and so that's also one of our big challenges, especially when the infections get into the poorer areas, that to try and contain the infection there is really a challenge. As far as our otolaryngology programs are concerned, our private practitioners are all out of work at the moment because the private practice system has essentially shut down, because we've stopped doing all elective surgery, and that's been going on for quite some time now. And that's partly to protect patients, but also to try and avoid infections coming into the hospitals, and also to ring fence services in the hospitals for COVID care. And then as far as the other precautions are concerned, we've been following very much the guidelines of the American Academy in terms of precautions in the office and precautions in the OR, as well as precautions when you're doing tracheotomies in these patients. We have a very, very conservative approach in terms of tracheotomies at our hospitals. We try and delay them for at least 2 weeks, and so we don't have an aggressive policy in terms of doing tracheotomies early. And so we're quite selective, but at the moment in our hospital, we're doing 2 to 3 tracheotomies per day on COVID positive patients. And so that in itself, of course, places a lot of sort of burden on our staff and on our resources, and on our OR time to try and get through these cases.
Dr. Fagan, are you doing the percutaneous tracheostomies?
Yes, I know that that's been a controversial area, but just this past week, we've started doing percutaneous tracheostomies, and the reason is really just time. We find that our turnaround time to get a patient from the ICU down to the OR and to go through all the donning and doffing and the whole process can take up to 4 hours per case, and we feel it's just not a good use of resources. So we now obviously selective in terms of who we do it on, but what our ENTs have started doing is they set themselves up in the ICU with a full open tracheotomy set at the ready, and then they will do a percutaneous tracheotomy. And then if they have any complications like bleeding or so, then they can jump in straight away and they can do an open procedure. So they're doing it with that proviso in place, that they have the scrub team there and the diathermy and the bipolar system, so they can intervene if there are any complications from a percutaneous tracheotomy.
Thank you. Dr. Goma, can you also give us a perspective on otolaryngology, either in the academic and private settings, as well as your experiences and how that's impacting, I guess, the specialty as well as the patient population in Egypt?
Thank you very much for this question. First of all, if I want to get just have a second about the testing here in Egypt, we start the testing on the patient and in contacts of the patient at the first. And right now, I think we suspect cases of COVID-19 from the symptoms, from the ground glass appearance in the CT of the chest. We also have rapid testing and the PCR. And we do it efficiently and sufficiently right now. And many cases, even mild cases, can be treated at home. And we use telemedicine to contact them and to follow them at home. This is number one. As regard of the ORL practice, most of the hospitals right now are caring the patients of the COVID-19. So elective surgery are decreased to 90% decreased. We do only 10% of emergency cases. And in my private clinics, I actually go daily into my clinics, private clinics, and I do surgery. If the patient willing to do surgery, elective surgery, I will do it. As I use my protective measure, it's okay. And some colleagues stopped doing surgery at the private hospital and at the private clinics. But from my view, why we stop? We can do surgery, and I did some cases, elective cases of surgery, and without any complication and without infecting me.
As it is in Nigeria right now, the number of otorhinolaryngologists we have, you can say is about 250,000, that's to say about 250 ENT surgeons currently in the country. Most of them are in the federal teaching hospitals. Only very few are in private practice. And we have a very strong society in the country, the Otorhinolaryngological Society of Nigeria, like the apex body. We try to use the association to coordinate most of our activities. As much as possible, when this disease initially broke, visually all the teaching hospitals have to take decision on how best to manage the situation. And regarding ENT surgeons, for instance, in my own institution, University of Abuja Teaching Hospital here in the Federal Capital, where I'm also the head of the department. So decisions were taken that routine clinics shall not run any longer. The same thing with routine theater sessions, operative sessions have been suspended for the time being, except for emergency cases. We still attend to emergency cases whenever they present, both in the clinic and also in the theater, with a rider that limited number of medical doctors and nurses should be on a duty at any point in time to avoid congestion while we're attending to this emergency. And of course, they must be adequately protected with PPPs and protective devices before attending to such patients. And again, we took a measure not to routinely examine the nose and the throat any longer. If, for instance, the pathology is domiciled in the ear, we don't have any business looking into the throat or the nose for the time being as a protective measure for everyone.
Thank you. Dr. Woodson, just in your experiences, several places that you've spent, what would you think there might be that we here from our experiences might be able to assist with and share in terms of knowing where the countries that have been discussed so far and the ones that you know about, knowing where they are, I guess, right now, we might be of some assistance? Or do you think I know they're on our website, and I know we've been working hard, but I think you have a perspective, certainly that I don't have, and that might be of value, giving us some insights.
Certainly the availability of the internet has really revolutionized medical care in a lot of African countries, where they used to rely on maybe some old secondhand textbooks. They can get all kinds of information on their cell phone, and they are very appreciative of the resources of the Academy and also the online resources that Dr. Fagan has been able to provide. So there is that going on. I know that all of us, even if information is available, we're not really accessing it or as aware of it until we actually need it. So having just-in-time information that's available when they need it. And I think at the present time, if they're not going to be worrying that much about how to do an aerosolized procedure without contamination, because that's not something they're, it's on their radar now, because they just aren't seeing the cases. But I think that when the cases, if and when the cases start coming, then that's going to be something that they will definitely appreciate having. I wonder about maybe there are asymptomatic or mildly symptomatic cases because the risk factors, the major risk factor, diabetes, and that's typically the type 2 diabetes, which goes along with obesity, and old age. The average age in some of these countries is so much lower, and there's so many other things that can kill you, like measles is still probably killing a lot more people in some of those countries than COVID. Although Tanzania is very good about getting everyone immunized for measles, but I think in places maybe like the Congo. But I just would wonder with Dr. Fagan and Dr. Goma in your countries, are you seeing the same pattern of risk factors with the elderly and these types of diseases as maybe a reason why there would be different patterns there?
I'm glad you asked that question. I guess, Dr. Goma, you could probably answer that first. The demographics or the morbidities, it's interesting to get a perspective on that in terms of the people that have it and that are either dying from it, or that are, the ones that are getting the tracheostomies. Are there other things that are going along with that are similar to what we're seeing in the United States?
First of all, the pattern here in Egypt, about 80% of the cases are asymptomatic or mild cases, and 20% only they suffer from the disease. And from this 20% of the cases, about 5% only need ICU. And in the ICU, 2% on the CPAP and about 3% on the ventilator. The risk factor for the patient going to the ICU is diabetes, hypertension, obesity, old age, and no talk about the smoking, because we heard about some papers about that smoking prevent COVID aggressiveness in the person. But I dismiss these papers, or these are 3 papers from China, from France, and from other countries. They say that smoking, the incidence of COVID in the smoking is less. But I dismiss these papers. The second thing, as regard of the children, we don't see many cases of the COVID-19 in children. So they actually influence adults, adolescents, and the death rate here in Egypt is about 2% only, and the infection actually more in the bigger cities, in the urban area, and it is less in rural areas.
Yeah, the prediction and the projection made by the World Health Organization and indeed the UN, I think is based on verifiable data that they have with them, and looking at how Africa has fared in the past was containing infectious diseases and similar illnesses, the responses, and equally looking at the volume of resource that is available in Africa, both human and material. So based on this, they were able to arrive at their prediction. But somewhat, sometimes you predict, but there are some other extraneous factors that you may not be able to take into consideration, which at the end of the day may prove you wrong in one way or the other. As we are speaking, Africa has a total of 206,780 cases. And out of this, have recorded 5,844 deaths and have discharged about 99,000 and some fractions. If you look at this, that's not entirely a bad outcome comparatively when you put this across what the record has been like in developed countries like the United Kingdom, Italy, and France, all right? And recently in the United States. And we, the scientists here in Africa, we're beginning to look inwards. What exactly could have been responsible for this type of record, unexpected record we are getting? Because the world and the prediction thought that we would have had something worse than that. And looking at some incidences, sub-Saharan Africa is a place that has been ravaged with lots of infectious diseases in the past and in the present.
Dr. Fagan?
Right. Yes, in terms of risk factors for patients doing badly, so far in the Western Cape, where we have the epicenter in South Africa at the moment, we're finding, like you have, that the diabetes, especially those that are untreated, obesity, patients with hypertension, cardiac disease, those are the ones that are high risk. If you're over 60 years of age, then you're unlikely to be ventilated. So we're having to be quite strict on that score. HIV, there's been a lot of speculation about whether it's going to expose people to worse outcomes, and also the impact of HIV drugs. But the early data, and it is early data, would suggest that patients with HIV do worse than those without it, whether they're on treatment or not. But we have to wait for more powerful data to come on from that perspective. And then tuberculosis seems to be a very small factor. But remember that tuberculosis and HIV also go together often. So we need to have some bigger numbers before we can really proclaim on that with more certainty. Yeah, perhaps I can also raise the issue about competing sort of diseases that we're facing at the moment. You know, in South Africa, like in most African countries, we've always been faced with an overwhelming burden of disease, and we simply can't treat everyone. And now, of course, this has added an extra large sort of load on our facilities. And just like you've had a debate in North America about what happens to the patients with the non-COVID diseases such as cancer, you know, we're having that same debate right now. And in practice, you know, there's been a large reallocation of staff and resources to COVID, but to the detriment of patients with other acute and chronic sort of diseases. And we're having that debate in our hospital right now as to how we should ring fence certain essential non-COVID diseases. And it's clearly a very big ethical dilemma that we face, but we have to face it and we have to debate it. And we have to essentially decide who we're going to treat and not treat. And that's the tough question that we have to answer.
So one of the things that, you know, as I reflect on what's going on in the United States here, I'm on staff at a hospital where there's probably two ICUs that are completely full with the COVID-19 patients, and another entire floor. And each of those ICUs has about 20 to 30 beds. And so, and then of course we know overall that there's over 2 million cases in the United States, and about 115,000 people right now have died. My hope is that on the continent of Africa that you've gotten ahead of it, and I mean, I'm glad to hear there are places where there's so few. What's your sense for whether you feel like this is, are you where the trend is, and whether you've gotten ahead of it so that the things that you're doing right now are going to hopefully allow this to plateau sooner rather than later, and go back the other direction, as well as you know, things that you see as that are ultimately ongoing needs in terms of how you practice. Dr. Goma?
I think the African nations, the epidemic started later than Europe and the United States, and this will give them a chance to deal with the situation. Second, also, there is studies about the BCG vaccine. The countries which vaccinated by the BCG vaccine, the patients suffer less in the respiratory tract as regard of the respiratory tract symptoms and signs of the COVID-19 than the countries doesn't use the BCG vaccine. And I think most of the African countries with both sanitation use the BCG vaccine, and I think and also, I think the cooperation between the African nations will play a good role in this. The third thing, I think also that the high temperature will reduce the respiratory tract infection and the transmission of the virus. All this, I think it will get Africa ahead of the virus and ahead of the crisis.
Dr. Fagan?
Yeah, I must say I'm far more pessimistic. I don't think we're going to, I think we're going to be totally overwhelmed by COVID for the next few months. We don't know how long for. Our health services in Africa simply aren't equipped to deal with it in terms of infrastructure or personnel, and I think we're in for a really hard time.
Dr. Woodson, what do you think?
Well, I'm on the pessimistic for reality, hopeful on the optimistic side, but I do think that there's real danger. In the United States, there's been a problem with rural areas not being as affected as urban areas, and that led to some kind of people feeling like they were immune, or actually even doubting whether or not this COVID epidemic was real. So I think there's been a lot of laxities in some of the rural areas and less urban areas. And what we're seeing now is real spiking in some of those communities. So the communities that were spared before are really spiking, and people are not following through on things that we know they should. You know, wearing masks. You know, people are kind of rebelling against that, or they're too casual about it. There seems to be a sense that, oh yes, things are going down just because the major driving area in New York is less. So I think some of this nonchalance or denial could definitely be a problem in some of the more unaffected parts of Africa now. So they may not have their guard up, or they may not follow through with some of the recommendations. I know in terms of Ebola, there's a real problem with, particularly in some areas of the Congo, with people thinking that this is a made-up disease. There are lots of other things that can kill you. So I could see similar attitudes popping up with this COVID-19. It definitely would come, you could sell it as something that was introduced by the outside culture. So I'm really worried about how the population will respond in terms of public health measures if and when the virus does get into those populations.
I think those are some good points. So I think the dialogue is so important, and the information sharing of what's going on in this country, as well as other places who have sort of, are experiencing the higher numbers. You know, you talk about, we're actually number one. I think Brazil is number two right now, and they were experiencing, or continue to experience, quite a bit of the problems as it relates to people not utilizing the measures that need to be utilized to prevent this from moving about and spreading. And so, those are all some definitely critical pieces, and hopefully other places are looking at us and learning from the things that should be happening that aren't happening, or that haven't happened. But the other thing I'd like to hear about is the prevalence of, and I think this is something that's being looked at internationally, is all over the places, with not only just in our country, the prevalence among physicians. And I think there's always a concern about, does it seem like now that otolaryngologists are, they're protecting themselves in a way so that you're not seeing necessarily an increased prevalence in our specialty of the disease, as well as hopefully not any increased morbidity from the disease in the specialty. Any comments on that? Again, I know you don't have the same numbers as we have over here, and I would say overall, at least the feedback that I've gotten, is that our specialty has managed to do a good job in not seeing any serious spikes in either physicians who have succumbed to the disease, or or have gotten it.
I think the international rate of this in the healthcare workers, including doctors, is about 20%. This is as I recall. Here in Egypt, so far, it is about 100 doctors die from the COVID-19. And a dozen of nurses and administrative in the offices and all this stuff. Here in Egypt, the incidence of this in the healthcare workers is low. I don't know why, but this is rare here. This is number one, and some papers they talk about the virus load and all this stuff. But the real here, it is about 100 doctors so far, and in our specialty, the otolaryngology, I didn't recall anyone die from the COVID-19 so far.
Dr. Fagan?
Well, just by chance, so one of my own residents, he tested positive on Friday, so it's happening in our own department right now, and that's despite taking good precautions, because we've been very careful in our department. We've actually purchased our own respirators and eye protection, and but I think we're all exposed, and it takes just one lapse in terms of being really careful about taking precautions, and you get infected. They're also very careful about not allowing anyone over the age of 60 or with any comorbidities to work with COVID patients. But of course, we're all at risk of being exposed to the asymptomatic patient, where we simply don't know that we're putting ourselves at risk. We've had many nurses being tested positive, as well as doctors around the country, and it is impacting on our ability to deliver our COVID healthcare service.
And I guess that kind of leads into maybe our final question about how this is impacting all of those patients that need care that don't have COVID-19, especially our otolaryngology practice, and how are they being addressed in your individual situations? We have done a lot of telemedicine here, and I'm interested in finding out whether that has been utilized in the same way. I mean, I wasn't doing anything other than emergent cases in my practice, and those were very few. And I had really become very adept. I still am very adept now using the telemedicine two platforms that I have. So I guess I'll start back with you, Dr. Fagan. What do you think in terms of the impact on the patients who obviously don't have COVID-19 that are a part of our practice? And of course, we don't really know everyone, because there are asymptomatic patients, but the ones that don't obviously have symptoms, what would you say about that?
Right. In South Africa, we have a real concern about what's going to happen or what is happening to our current patients who are not seeking care or not being able to access care. And also the long term, because we find that many patients are not accessing the HIV drugs or the TB drugs or other chronic medications, and in terms of our otolaryngology care, unlike the USA, where you can shut down your cancer services for 3 months and then you can ramp up thereafter and just increase your outputs. Here in our country, we work to maximum capacity anyway, and at the moment, our cancer operating lists have been cut back quite severely, and we know that there are going to be many patients who are going to die because they can't access care, and so we're looking not only at the short-term acute impact of not being able to access care, but the long-term effect as well. and we have to monitor that. But but it is going to be quite significant.
Dr. Goma?
I think also there is a concern about the patient which are not COVID-19. But in all specialties in Egypt, we see a reduction of the number of the patient, non-COVID-19 patient going to the clinics. This is real huge. The second notice is the patient with a cancer, with tumors, going to the cancer institute. There is no problem for this patient, but the chronic patient is a patient with other diseases are decreasing. This is surprising. Surprising. The patient is feeling like the clinics and the hospitals are source of infection. This can be an answer. The patient with tinnitus, the patient with common cold, the patient with acute follicular tonsillitis. This patient, we didn't see them a lot this day.
Yeah, I think we definitely are seeing people who are staying away from the hospitals, here, who the concern is, are they gonna have a heart attack at home, because they're afraid of being exposed to all the COVID-19 patients, that are in some of the hospitals here, and even in hospitals where that may not have as many of them, people don't know, and they're concerned. And so I think the information and the education is really key as a part of that, almost like the public health, public service announcements, things like that, to really encourage people to not stay home if they think they're sick. Dr. Woodson, would you have any questions or comments that you'd like to make that we may not have covered? Or
I'm interested in whether or not in Egypt and South Africa you're running into this post-COVID syndrome in children. That's a Kawasaki-like illness. It seems to be very severe.
Good question.
And that raises the idea of having this post-inflammatory, post-COVID inflammatory thing is also raises a lot of fears about whether a vaccine might actually induce some autoimmune disease.
Dr. Dr. Fagan, would you like to start there?
Right, I'm not aware of it having been a significant problem here. There might be the isolated case, most certainly. But as I said earlier, we're still early in the pandemic, and I'm sure we're going to see what you've experienced in North America as well.
And Dr. Goma?
Actually, the incidence of COVID-19 in children is low, and only 0.9% of the cases go to the ICU. And we, as I remember, we not noticed any Kawasaki syndrome in children here in Egypt. Yeah. So the kids are behaving well, and the incidence of infection and even the prognosis in children is so good, so good.
Among the children here, incidentally, we have not been recording fatalities among children down here in Nigeria, and to the best of my knowledge, across Africa. And that seems to be in tandem with the earlier prediction regarding the disease, that children are not as severely affected when compared to the elderly ones, 60 and above, when compared to them. So I would say that the children are somewhat, they have been somewhat protected down here, because I've not really been recording very serious cases among children. And I think it's only one death that I know about a child that has been COVID-related down here in Nigeria among all the other cases recorded so far. And regarding the healthcare givers, I have mentioned earlier on that close to 1,000 healthcare givers have been infected in the process. And we have also had some fatalities in the process. We have had some deaths among doctors, among nurses, among other um, health workers within the country. And that's why the various societies and associations have come out boldly to insist that the government must ensure that the protective equipment needed to manage COVID cases are available for our health workers to be able to carry on with fighting this disease.
Well, with that, I would like to say on behalf of the Academy, I'd like to thank you all for sharing your experiences with us today. And I want to remind all of our listeners to continue to visit the COVID-19 resources page at entnet.org and join your colleagues from across the globe at ENT Connect to share information and inspiration together. And, you know, this dialogue is so important because if we're maybe at different places with this COVID-19 pandemic, and certainly any of the information can be helpful for us all learning from one another wherever we are. And with that, I'll say now, as always, we are one. And thank you again.
This has been Frequency, a production of the American Academy of Otolaryngology, Head and Neck Surgery. To download more episodes and our mobile app, please visit our website at entnet.org/frequency. That's FREQUENTCY.